Hi, it's Dr. Centeno, and today I'd like to talk about treating craniocervical junction or upper cervical instability. This is actually the presentation that I am giving at the American Academy of Orthopedic Medicine in Clearwater, Florida this week. And this is a very important topic for me because for years we've seen many of these patients who we've been able to help somewhat, but these are patients who really don't get much relief from anything, and they've got a horrible problem. So I developed a very novel and first of its kind injection to try to help the ligaments in this area, because when patients have this problem, there are some key ligaments that are loose. So that's what this presentation is really about. Now, many times I'll produce things for patients and then sometimes for physicians only. This is going to be more a physician type lecture, but I'm going to try to, as hard as I can, to simplify some things if you're a patient watching. So from a 30,000 foot view, what is CCJ instability? Basically, it's excessive motion of the C0 through C3 vertebra, or the upper neck bones. And most cases are what's called subfailure, meaning that there are lax ligaments and the ligaments are not torn in half. So you see to the right there what can happen when there's a true, very large through and through tear in the transverse ligament. That's an increased atlantodental interspace and cervical flexion on an X-ray. But that kind of injury is relatively rare compared to the much more common subfailure type, where ligaments are more stretched in this area. So how did I get involved in all of this stuff? My partner and I had a practice that had a concentration of traumatically injured neck patients, and a percentage of these seemed to have upper cervical symptoms. Our interventional workup, meaning we would do the traditional interventional spine workup where we would inject the cervical facet joints under fluoroscopy, and the most common joint that was injected that would cause headache and dizziness and things like that would be C2-3. But we'd inject C2-3, we'd numb it up, and a certain percentage of those patients would still have issues. And then we'd go on to inject the C0, C1, or C1, C2 joint and find that we could help more patients, that some of these patients had high upper cervical problems. And as a result, we became very good at injecting the high upper cervical facets. In fact, I would say that we're probably the two most experienced physicians in the United States when it comes to C0, C1, and C1, C2 injections, and that we've done each of these levels about 1,000 times in our clinic. So we became very experienced in the upper cervical spine. Now, while some of those patients that we injected in the high upper cervical spine at C0, C1, and C1, C2 had excellent block results, meaning we could numb out their pain, many of them didn't have long-term pain relief. So there was clearly something else going on more than just an injured joint there. Hence, we started to explore what that could be, why we had these long-term non-responders, what was wrong with them, and what we could do for them. So let me give you a primer first on the craniocervical junction, or the CCJ. When we look at how babies develop through embryology, it's pretty clear that the head and the upper neck are one segment, meaning they develop together. And that's why problems in the upper neck can lead to headache, because your brain doesn't really distinguish between your upper neck and your head. Now, the upper neck is also very rich in position sensors that coordinate head, eye, and inner ear data. Hence, upper neck issues can lead and cause to dizziness or vertigo or a sense of imbalance. The original name for this syndrome goes all the way back to the 1930s. It was called the syndrome of Bar-Leau, and that was named for two physicians from Belgium. And they described what they called a posterior cervical sympathetique syndrome. I'm going to feign some French there. And that included headaches, dizziness, disorientation, and problems thinking. And the vertebral artery, cervical sympathetic chain, many things have been implicated through the years as a cause for this, but it's become more clear of late that some of these patients really had upper neck issues. If we look at where the upper cervical facet joints refer pain and realize that the facet joints in the upper neck are just the joints in the spine. So where do these spine joints refer pain? Well, it's interesting. They all cause some sort of headache. So basically the C2-3 joint, you see the pain referral pattern there off on the left. The C1-C2 joint, you see it off on the right there. The C0-C1 joint, you see it off on the right there. So that's, if we inject these joints and we piss them off, that's where they're going to refer their pain. So the upper cervical joints can clearly refer pain into the head. Getting back to CCJ instability, there are two prime ligaments that we think are responsible for this problem, and those are the alar and the transverse ligaments. And if you look on the left there, they kind of form like a little cross. And the cross is actually also made up of what's called the apical dens ligament. But the part going sideways on the cross is the transverse ligament. And then the alar ligaments come up like two wings from the dens that come up from the dens or the tooth-like process of the C2 vertebra, and they grab onto the skull base. And off on the right there, you can see from a top-down view of the C1 and C2 bones, how the transverse ligament, which is what the arrow is pointing to, acts almost like as a seat belt for the dens. And you can see that it's a pivot point. You can see that the C1 vertebra is going to rotate there around the C2 vertebra. So these ligaments function to keep the dens from hitting the spinal cord in cervical flexion, which is a good thing. They control C1, C2 motion in rotation, so this is a pivot point. And as we'll see, there are all sorts of other things these ligaments do. If we look at the alar ligament, it controls and limits rotation. And probably the most interesting thing about this ligament is that when you turn your head, the opposite alar ligament is tight. So if you turn your head to the right, the left alar ligament is what's holding things together. If we look at the transverse ligament, again, this acts as almost like a seat belt for the dens, and it's a major pivot point. In fact, half of all your neck rotation occurs at the C1, C2 vertebra. So this stabilizes everything as you turn your head. It also stabilizes things as you look down. If this isn't there as you look down, then that dens or that tooth-like process coming up from the C2 vertebra into the C1 vertebra could actually injure your spinal cord. So what causes this kind of upper cervical instability or CCJ instability? Trauma to the head, motor vehicle collisions. I've seen patients who hit their head against the back window in a pickup truck in a car crash. I've seen patients who have had things fall on their head. I even saw one guy that tried to do some sort of crazy CrossFit maneuver where he was putting tremendous weight on his head by arching his entire body onto his head. So lots of different mechanisms, but they all involve some injury or trauma to the head. Now, the typical patient with CCJ instability basically is pretty miserable. Activity makes everything worse. They have severe headaches that can usually be helped only temporarily by a very specific type of upper cervical manipulation, and there are only a few chiropractors or physical therapists talented enough to know how to do this. And other associated symptoms can vary depending on the severity of the instability. Mild instability will cause headaches, dizziness, cognitive problems, visual issues, all the way up to severe instability, which can even cause, I've seen, numbness and tingling in the leg, or perhaps changes in position sense so that other things get messed up where you get numbness in the leg. Physical therapy will usually make these patients worse, and all interventional care only really helps a little bit. So upper cervical facet injections, prolotherapy, PRP, stem cells, steroid shots, they only help a little bit. Now, since there are very few things that help these patients, some of them end up with an upper cervical fusion, and you see a picture of one there, basically where you put in some rods and some plates, and you screw into the skull itself, and you put in some rather draconian hardware to try to just stabilize everything. Now, this has obvious problems. It's a very high-risk surgery. In addition to that, the other big issue is that once you fuse things together, the joints below, in this case, are going to get overloaded and start to develop problems. So as I tell my patients, while sometimes, very rarely, it's a necessary evil, fusion is a dog with really big fleas. So can we image CCJ instability? The answer is we can. There are some different ways to do it: dynamic motion X-ray, rotatory CAT scan, or upper cervical MRI with a head coil.
And open your mouth. That's perfect. Right ear to right shoulder.
And you can basically see
Pull head to center.
that we can see the upper cervical
there you go.
bones.
Left ear to left shoulder.
And we can watch those upper cervical bones move in real time to try to see if they're moving too much. On rotatory CT, we've known how to do this since the early 90s, and this is based on a study that was able to find that about a third of patients with chronic whiplash type pain had asymmetrical motion of the upper cervical bones, indicating that they probably had some instability. And then MRI imaging in this area has been really interesting because the original papers were done by a Norwegian radiologist by the name, or neuroradiologist by the name of Krokenes. And the data initially looked good for the association of signal changes with a chronically disabled whiplash patient. So basically what happened is that a physical therapist in Norway sought out a neuroradiologist to try to image this area. He had a population of patients that he could help only temporarily who had upper cervical problems. There was a study done that seemed to show an awful lot of these patients had issues in the alar and transverse ligament that could be picked up on MRI. And however, the last paper by Krokenes was really interesting because what it seemed to show is if you looked at all comers from who just had neck pain walking into an emergency room and you did MRIs on those patients, you couldn't really find many that had issues in the upper cervical spine on MRI in these ligaments. The problem with that paper is that this isn't a very common problem. So obviously it's very hard to find with patients who just have some neck pain in the emergency room, most of whom won't have serious injuries. So this is a percentage of patients who have serious injury that have this issue, but regrettably that study just seemed to be done in the wrong setting, i.e. you're not going to find many patients with very serious injuries who just report a little neck pain in the emergency room. So traditional prolotherapy for CCJ instability. Prolotherapy is a technique where you can inject the ligaments to try to tighten ligaments. But the problem is that you can't get at these ligaments from the back, and that's where these prolotherapy sessions are performed. And blind prolotherapy in the upper cervical area is not a good idea. And we've done fluoro-guided prolotherapy in this area and really had mixed results. So, is there another way to get at these ligaments? This is a question I've asked myself for many, many years because we've had many of these patients, and while we've been able to help some, there really needed to be another way to do this. So a while back, a couple of years ago, I had this idea that it might be possible to come in from the front rather than trying to get at these from the back. And the eureka moment was recognizing on this model we had in the office that there was a little gap that we could go through. Now, I spent a year researching this and consulting with high-level colleagues to try to make sure that this was something that was a relatively safe thing to do, and that to try to really test all of my assumptions about how this would go. So this is what I'm talking about. There is an articular gap. So what that means is there's a gap between the C1 and C2 bones from the front. This area can be reached via a small needle. So this is how you would go, and that's the C1 and the C2 bones being shown from the front there. This is a top-down view of where we would come from to get the alar and transverse ligaments, which are shown there. And this is a side view of how we position the needle. To make this work, though, the neck needs to be flexed, the mouth needs to be opened, and the tongue needs to be depressed because the tongue is initially in the way. And we use this little device to do that. This is a device that we borrowed from the field of GI. It's a device that's normally used for endoscopy and other things, but we borrowed it and used it for this purpose. This is the back of the throat, looking at the nerves and vessels versus where we insert the needle, showing that this is a safe place to put this needle. And before I really get into the results here and show you how it's done, I need to make sure that any physician watching this understands that unless you've done 100 or more upper cervical facet injections under fluoroscopy in the high upper cervical spine, you're not qualified to do this procedure. And literally that means there are probably only about 100 to 200 US physicians who have the interventional experience to pull this off. So please don't try this at home. You cannot do this procedure under ultrasound guidance. It can only be done safely under C-arm fluoroscopy. And please don't attempt this if you're a nurse practitioner or a naturopath who's doing some injections under X-ray guidance. So this is a anesthesia-only procedure because we don't want the patient to move in any way. We also add a anticholinergic agent to reduce secretions at the back of the throat. We obviously extensively clean off the back of the throat using chlorhexidine. IV antibiotics are used to reduce the infection risk, and we use a 25 gauge, relatively thin 4 11/16 inch needle. So this is what the procedure looks like. You can see me off to the right there as a blow up of the picture off to the left, placing a 25 gauge needle into the back of the throat area, and you can see there the C-arm fluoroscope that's showing me where I'm going. We use a flexible endoscopic imaging device to check the needle placement in the posterior oropharynx to basically make sure that I'm going in the right area and avoiding all necessary structures. And This is what it looks like. You see the needle off on the left there, going through that little hiatus or articular gap. You see the endoscope off on the right. And we see contrast kind of going up in the direction of the alar ligament there. Now, unless you look at these films all day, it's hard to see what's being shown here. But in this one, if you go too far laterally, you can pick up a piece of the C1, C2 joint capsule. And that's something, it's okay if it happens. You just get a C1, C2 joint injection. But obviously, then you're not placing the injectate where you want it to go into the ligaments. This is the left alar ligament being injected, which is highlighted there by the arrows, and that's contrast in the ligament, showing beautiful spread in the ligament. And this is the transverse ligament being injected in the same way. Now, we've done these procedures with platelet-rich plasma and bone marrow concentrate primarily, and we started last year in February, and this is all the way up through last week. What's interesting about all of this is that we didn't want to talk about this until we had done at least 10 of these, and we had some results to discuss. And as you can see, these are various patients, and you can see the outcome notes there. But what's interesting is, of the 7 patients that we've done 10 injections in, we've had some pretty good success. And even though it's 5 out of the 7 patients that have responded well, what's really interesting is that these were patients that were helped by nothing else, that had extensive care and interventional and injection care beforehand. You can see we've used platelet-rich plasma or bone marrow concentrate. Bone marrow concentrate is a same-day stem cell procedure. And the 2 patients that didn't respond, one got a suboptimal injection, so that could have been the cause of the non-response. And the other, we later found out, really did not, or really had most of his pain coming from a facet joint. So he had had a poor workup before he came to us. He was a medical provider himself, and he wanted to head the direction of getting this procedure. We kind of warned him that you could have upper cervical facet pain that's really causing most of your issues, but we proceeded based on his or a discussion with him. So we're now going back and retreating that area, and we may come back to this to ultimately solve his long-term problem. So pretty darn good results, some of which have been life-changing for these patients. Patients that are now going on hiking trips where they couldn't even consider doing that before. Patients that are going cross-country skiing where they couldn't do that before. Patients that couldn't sit in a meeting for an hour, and they're now doing that on a regular basis. So some pretty spectacular results in a very, very difficult to treat population. So in summary, injecting these ligaments is possible. It can be done. The procedure appears to be safe. This is a first of its kind procedure in the world, and the results are very promising. But I have to, again, make sure that you understand that this is a high-level interventional procedure that's still investigational. So we are taking it very slow. We're about to move from kind of proof of concept into research mode with this. And again, very promising stuff, but please don't try this at home. So thank you so much and have a wonderful day.